So now, finally, I'm going to talk about the integration of surgery and systemic treatment in the treatment of kidney cancer. This is something that's near and dear to my heart and something that's an active part of clinical research here at MD Anderson Cancer Center. Again, stage. The vast majority of patients present with localized or locally advanced disease, but it's a sad reality that almost half of patients with kidney cancer will at some point in time in their disease process develop metastatic disease, which, as we all know, is currently not curable. If we were having this seminar 6 years ago, there wouldn't be a whole lot to talk about. I could just show this slide and sit down. Many of you are probably wishing that was the case today. But for locally advanced disease, we basically took out the kidney. And for stage 4 disease, we took out the kidney and then gave some form of systemic treatment, usually cytokines. But as I said, now we have this embarrassment of riches. We almost have too many therapies and we don't even know how to use them all. How do we integrate surgery into the context of these different treatments that we now offer patients in the setting of metastatic disease? One of the sad realities of these therapies, and many of you know this in the audience, is that there's no home runs. Unfortunately, all of these therapies control the disease for a period of time, and this is just the molecular pathways that are targeted by these therapies, but in almost every patient, resistance will develop, and then you have to move on to the next treatment. So I'm going to talk about how we integrate surgery and systemic treatment in 2012 and the role of cytoreductive surgery, and then introduce the concept of presurgical therapy, something that we've been studying here at MD Anderson that's shown some promise. So these were two randomized trials that were done, one in the United States, one in Europe, that demonstrated the benefit of patients undergoing cytoreductive surgery. So this is the EORTC trial where patients were randomized to upfront surgery followed by interferon versus interferon alone. And this is the SWOG trial done in the United States, again, demonstrating the benefit of undergoing nephrectomy prior to interferon versus interferon alone. Many surgeons referred to these trials as surgery followed by ineffective therapy is better than ineffective therapy alone. You can see the response rates were only 3–4%. And so the question is, now that we have more effective therapy, what's the role of surgery in the context of patients with metastatic disease? We don't even know how cytoreductive surgery works. We have no idea. Does it reduce the major portion of tumor burden? Does it produce some sort of immunologic phenomenon where some tumor antigens are exposed, or there's the removal of an immunologic sink? Is it an alteration in the metabolic milieu where somehow taking out someone's kidney and altering the pH of their body somehow is anti-tumoral? Or is it that, taking out the mothership where, some sort of endocrine or paracrine phenomenon is being removed that promotes progression and metastasis? But in truth, we have absolutely no idea how it works. Well, why not take out everyone's kidney in the setting of metastatic disease? Well, anyone that's ever had that operation, and I know there's many of you in this audience, the morbidity or side effects can be significant, and people can die from this operation. It's only been proven beneficial in the context of interferon, and it's quite possible that many of your patients will spend the majority of their time left on this earth recovering from that surgery. We've seen some patients' disease explode postoperatively, and they never even get to go on and get targeted therapy after surgery. And these newer therapies, maybe they'll cause the primary tumor to shrink. Maybe we don't need to take out everyone's kidney in the setting of metastatic disease. Well, the French are testing that question as we speak. And this is the so-called Carmina trial, where patients are randomized to upfront nephrectomy followed by sunitinib versus sunitinib alone. It's a non-inferiority design, and the randomization is 576 patients. Now, there's a problem. This trial is not accruing at all very well. And the reason why is that patients don't like to have surgery randomized. It's very difficult. They don't like a computer saying you're going to have surgery and you're not. So the accrual to this trial has been very difficult. And it's going to be many, many, many years before we have an answer. And arguably, is sunitinib even going to be relevant many, many, many years from now? And what do we do in the meantime? I have patients showing up in my clinic every week with metastatic disease. What am I supposed to tell them? Am I supposed to take their kidney out or not? Well, there is evidence to suggest that removing the kidney in the context of metastatic disease is beneficial. This is retrospective data from the expanded access trial with sunitinib. Now, what they noted was that those patients who had their kidney removed, not necessarily cytoreductive surgery, could have been any time in their past, but those patients who had their kidney removed, when compared to patients who were treated with their kidney in place, the patients who had their kidney out had a much better response rate than those patients treated with their tumor in place. They also had a better progression-free survival and a better overall survival when compared with patients who were treated with their primary tumor in place. Now, this is retrospective, it's biased. The people that had their kidney left in place may have been for a very good reason, like they were on death's door and really couldn't have their kidney removed. But it is data, and it does show a benefit to being treated without your kidney in place. More recently, Tony Schwery at Dana-Farber presented this data, and these are patients who presented with metastatic disease with their primary tumor in place. Those patients who had their kidney removed prior to getting targeted therapy had a more than doubling of their survival compared to patients who were treated with their primary tumor in place. Admittedly retrospective, admittedly biased, but it does give us some guidance that there may be a benefit to removing the kidney in the setting of targeted therapy. That said, as I just said, cytoreductive surgery is not for everyone. There are clearly a group of patients who are not going to benefit from this surgery. We recently did a study to try and identify whether or not we could accurately pick out those patients and save them from a surgery they're not going to benefit from that was going to be highly morbid. So we had 566 patients that we looked at, and we compared them to a group of patients who were treated with their primary tumor in place, 110 patients who got medical therapy only. And we compared and looked and tried to identify which factors predicted for outcome. Now, those of you that know me and know MD Anderson know that we can be a very aggressive surgical place. We believe in cytoreductive surgery. So you know that these patients who did not have surgery are probably the worst of the worst. And in fact, the median survival of the patients who were treated with medical therapy only was only 8.5 months. So we then looked at our surgical population and we said, okay, those patients who underwent surgery, if you didn't live at least 8.5 months after surgery, then you probably didn't benefit from that surgery. And we asked the question, what factors predicted for you to live longer than that 8.5 months that the medical therapy alone group did? And these are the factors that we identified. Those patients who had a low serum albumin, which is sort of a overall nutritional status sort of lab value, an elevated LDH, which is again another blood test, the presence of liver mets, the presence of symptoms due to those metastases, retroperitoneal lymph node involvement, again, going back to those lymph nodes, it's bad, supradiaphragmatic lymph nodes, and locally advanced T-stage. All of those features predicted for a worse outcome. And what we found was that if you had three or less of those features, those patients did significantly better than the group that received medical therapy alone. But if you have more than three of those features, your outcome was basically the same or worse than the medical therapy alone group. And so now we're using these features to prospectively select patients for surgery. So I'd like to ask the question, can we do better than this? Is the relevant question whether or not surgery should be incorporated into the management of kidney cancer? Or is there a more relevant question that we can ask? And I would argue there is. So I'd like to talk a bit about the concept of presurgical therapy for metastatic kidney cancer. Presurgical therapy means to give some targeted therapy for some defined period of time, then take the patient to surgery, and then resume the targeted therapy after surgery. And some of you in this room have participated in those trials. The potential benefit is that you can potentially use the therapy as a selection process so that the patients who are doing well are the ones you take to surgery, and the ones that aren't doing well, you spare them a surgery they're not likely to benefit from. It allows us to harvest tissue that's been treated with these agents so that we can study it and figure out how the targeted therapy affects the tumor and what pathways are turned on and off to help us generate the next generation of treatments. It may shrink the primary tumor and make the surgery easier, but arguably I think the most important aspect of this is it allows us to spare patients surgery they're not likely to benefit from. There are potential pitfalls. Targeted therapy doesn't just target the tumor. It also targets wound healing, and that's why many patients who get this form of therapy can have wound complications. It's also possible that the tumor may not respond to the therapy and may grow, so that you may have a patient who was a surgical candidate all of a sudden become not a surgical candidate because the tumor has grown. And I put there more ectomies equals worse outcome, meaning the more things I have to take out of you to get your tumor out, the less likely it is you're going to do well. And timing is everything. If you're getting targeted therapy and you're responding, why would I want to stop that to send you to surgery? And as a surgeon, if you're not responding to your targeted therapy, why would I want to take you to surgery? So the potential benefits of this approach are that the primary tumor may shrink, may downstage or downsize, and make surgery easier. As Dr. Karam talked about in his talk, the importance of nephron sparing, maybe we could do partial nephrectomies on everybody and save some kidneys. It may make the unresectable resectable. It may improve prognosis. In patients without metastatic disease, it may eliminate micrometastatic disease. And as I said, it could be used as a litmus test. But there are risks, and those include increased surgical morbidity, lack of response, and there's even data, some preclinical data that suggests that in some cases, targeted therapy treated in this fashion may make the biology of the disease worse. Well, we've conducted several presurgical trials here at MD Anderson. This is the bevacizumab trial, where patients were treated with bevacizumab or Avastin, and then went on to surgery after 2 courses, and then went back on bevacizumab after surgery. And we recently completed our sunitinib trial. In this trial, patients received 2 courses of sunitinib, followed by nephrectomy, and then went on to receive sunitinib postoperatively when they had a response. And again, this is my axitinib trial that I talked about earlier, where patients with locally advanced disease receive 3 months of axitinib and then go on to curative nephrectomy. So some of the things that Jose talked about during his talk for the treatment of the incidental renal mass, what he showed you was an evolution in surgery over time. So 10 years ago, everyone got a nephrectomy, and it was done open, and it was very morbid. And then people started to say, hey, maybe we don't have to do a nephrectomy. Maybe we could do a partial nephrectomy. Maybe we could do a laparoscopic partial nephrectomy. Every one of those advances had to demonstrate that it was equivalent to what we were doing then to be accepted. So it had to show oncologic equipoise or equivalent cancer control. And I would argue that that was the most important hurdle that had to be jumped by each of those advances to become accepted. It also had to spare nephrons, and I would argue that the least important feature is that it's minimally invasive. If you have a minimally invasive operation that doesn't work versus a maximally invasive operation that does, which would you choose? So I would argue that this neoadjuvant or presurgical therapy approach has similar hurdles to jump. First, it has to be safe. Second, it has to improve patient outcomes. And I would argue that the least important feature is that it downsizes or downstages tumors. It's the rare patient that presents that you can't resect. It'd be nice if it shrank the tumors, but I would argue that's the least important feature that we're looking for with this approach. So let's look and see whether or not neoadjuvant therapy is safe. These are 2 CAT scans, or one's an MRI, one's a CAT scan, and what they demonstrate is this patient here was on presurgical sunitinib, had surgery, and then went on to get sunitinib after surgery. What I didn't know, I was a surgeon, what I didn't know was he started sunitinib 2 weeks after surgery. And he had complete abdominal wall dehiscence. That's actually his greater omentum sitting on his abdominal wall. What's even more concerning is the patient didn't realize he had a problem. He actually went to the MRI. This was his repeat staging study. He had no idea that there was a problem. When then he came to clinic and we saw that, and we're like, oh my God. And this is a patient on the bevacizumab trial, and she had abdominal wall dehiscence 4 months out from surgery. And that's her small bowel. You can actually see it on the abdominal wall. So we wanted to ask the question, is this safe? So we did a retrospective study looking at 70 patients who received presurgical therapy, and we compared them to 103 patients who had upfront cytoreductive surgery, and we looked at complications over 12 months. So what we noted was, much to our relief, that patients who had presurgical therapy did not have more complications than patients who had upfront surgery. And they also did not have more severe complications. However, they were more likely to have late complications. They were more likely to have more than one complication if they had a complication. And they were more likely to have wound complications related to the targeted therapy impacting wound healing. And that's shown here in a multivariate analysis looking at all these different factors which predict for poor wound healing. The only factor that was significant was presurgical therapy. So we acknowledge that patients who get this form of therapy before surgery do have a higher incidence of wound complications, but they don't have a higher risk of overall complications. I hope I'm being clear on that. They're more likely to get a wound complication, but in terms of overall complications, it's exactly the same as those patients who have upfront surgery. So we said, okay, if patients are more likely to have a wound complication, can we predict who those patients are? Because then maybe we can do something different at surgery to protect their wound. Maybe we can put in retention sutures or leave the staples in longer or something like that. And what we did find was that patients who had a decline in their serum albumin while they were being treated did have a higher incidence of wound complications. And so now in patients that are being treated, we follow that variable. And in those patients who do have a significant decline in serum albumin, which is probably a marker of nutritional status, we're more likely to do more things at the time of surgery to reinforce their wound. But we were relieved to find out that those patients who received presurgical therapy did not have a worse survival than patients who had upfront cytoreductive nephrectomy followed by systemic therapy. So they may not be doing better, but they're not doing worse. And that's an important feature. That's shown here graphically. So what about primary tumor downstaging? Are we seeing downsizing? Well, we were taught classically in the era of immunotherapy with interleukin-2 that those patients treated with their primary tumor in place, the primary tumor never responded. And that, in part, served as the impetus for us to start doing cytoreductive nephrectomy because the primary tumor never responded. Well, these are patients that have been treated here at MD Anderson. This is a patient who had a very locally advanced tumor here in the left kidney and also very large lymph nodes. And if this was done as an upfront cytoreductive nephrectomy, it would be a huge operation. He was treated with sunitinib and had dramatic regression in the primary tumor. The nodes all went away, and he was actually able to have a laparoscopic nephrectomy. Arguably, he benefited from this approach. This is a patient that we treated with axitinib. Again, you see a very locally advanced primary tumor here, treated with axitinib, and you can see there was dramatic regression of their tumor. There's a look at the specimen that we removed. Here's the tumor sitting in the kidney right here. And arguably, this patient probably could have been treated with a partial nephrectomy. I actually wanted to do that, but they were reluctant. This is another patient that received neoadjuvant axitinib therapy. Again, you can see very large, locally advanced tumor sitting here in the right kidney. And after 3 months, dramatic regression of their primary tumor, such that this patient would have to undergo an open nephrectomy. This patient can undergo a laparoscopic nephrectomy, much less morbid. And there's a picture of the specimen. You can see the dramatic reaction. This all used to be viable tumor, and it's all been killed by the axitinib, such that there's only a rim of tumor present. So the question is, are these just anecdotes? Or can we rely on these agents to reliably downstage tumors? Because I would argue if that's true, as a surgeon, let's give it to everybody. Because then maybe we can offer all of our patients partial nephrectomy. Well, what's the data? This is some of the first data that was published in the literature looking at 17 patients who were treated with their primary tumor in place with sunitinib. And you can see that only 23% of patients actually demonstrated a response, but those that did had a response rate of 31%. These are data from the Cleveland Clinic where patients, again, were treated with sunitinib, and you can see that the overwhelming majority had little, if any, response in their primary tumor. And in fact, some patients, their tumor grew while on treatment. This is data from our bevacizumab trial, again, a recurrent theme. The overwhelming majority of patients had little, if any, response in their primary tumor in response to therapy. And this is data using sorafenib done at University of North Carolina. Again, a very similar theme. There was some dramatic regressions, there were some dramatic progressions, but the vast majority of patients had little, if any, response in their primary tumor. So we wanted to ask the question sort of once and for all, are we going to see primary tumor shrinkage? We looked at 168 patients who were treated with their primary tumor in place. The reason why they were treated with their primary tumor in place is listed here. The vast majority either were not good surgical candidates or were enrolled in a clinical trial. These are the different therapies that they received. The vast majority received sunitinib, which is the frontline standard of care, with other therapies intermingled. And here's the response. We had some patients who had dramatic progression of their tumor, some that had dramatic regression of their tumor, but the vast majority of patients had really little, if any, response in their primary tumor. One of the other things that's very common in the literature, common in the community, is that patients who have venous tumor thrombi, particularly large venous tumor thrombi, many of their community physicians will say, here, take this sunitinib, it'll shrink your thrombus and then it'll make the surgery easier. And a significant percentage of patients will present to me on sunitinib. So is there data to suggest that that's true? We had 48 patients in this series with different levels of tumor thrombi that were treated with these agents. And unfortunately, a recurrent theme, the vast majority of patients had little, if any, response in their tumor thrombus, and in fact, 15% of patients progressed while they were receiving the treatment. Only 10% of patients actually demonstrated shrinkage of their tumor thrombus in response to treatment. So I would argue that the initial body of evidence would suggest that the significant primary tumor downstaging is not going to be realized with the current generation of targeted therapy, although I must confess I've been quite impressed with the responses that we've been seeing with axitinib. Every patient has had a response. So here's the report card on presurgical or neoadjuvant therapy. Is it safe? I would argue, yeah, it's safe. I mean, we are seeing some more wound complications, but those are pretty easily dealt with. So does it reliably downsize or downstage tumors? I would argue, no, it does not. So is this worth pursuing? Should we continue to do this clinical research at MD Anderson and around the world to determine whether or not this has a role in the treatment of patients? I would argue, yes, we should, for the following reasons. In our bevacizumab trial, 50 patients were enrolled, but only 42 patients actually underwent surgery. And in fact, 6 patients had disease progression and went on to salvage systemic treatment rather than nephrectomy. So I would argue that those 6 patients were saved from a surgery they were not going to benefit from. In our series, we asked the question, is there something about presurgical therapy that we can use to predict prognosis? And can we use the primary tumor as a biomarker to predict outcome? So this is a spidergram looking at responses in the primary tumor. And what we noted from this was that in those patients who did respond in their primary tumor, they responded early. So if you don't see it early, you're not going to see it, and there's no point in continuing treatment if you don't start to see some shrinkage. And in fact, what we noted was those patients who had at least a 10% reduction in their primary tumor size went on to have their tumor shrink almost 25%. Whereas if they did not have that 10% shrinkage in the first 60 days, they were likely to have little, if any, response. So we could predict who was going to respond in their primary tumor, and the question was, can we use that as some sort of biomarker? So we looked at 75 patients who were treated with sunitinib with their primary tumor in place, and what we found was that those patients who had a greater than 10% response in their primary tumor had a significantly better survival than patients who did not have a shrinkage of their tumor of greater than 10%. And if they had a greater than 10% response within 60 days, their survival was even better. And that was in univariate analysis, and that also held up in multivariate analysis. So for the first time, looking at the primary tumor's response to targeted therapy could be used as a prognostic variable to predict outcome for patients. Interestingly, across the pond over in Europe, there was another study looking at sunitinib, and independently they arrived at the same conclusion that we did, and that was that those patients who had a greater than 10% response in their primary tumor when treated with their primary tumor in place had a significantly better outcome than those patients that did not. So I would argue that cytoreductive nephrectomy is not a question of if, but really more a question of when. And this is a trial that's currently ongoing in Europe through the EORTC. It's called the SURTIME trial, where patients are randomized to upfront cytoreductive nephrectomy followed by sunitinib versus 2 courses of sunitinib followed by cytoreductive nephrectomy and then continued sunitinib. So this will look and examine the timing of nephrectomy, not whether or not we should be doing nephrectomy. And I think that this is a much more relevant research question, and actually this trial is accruing quite nicely over in Europe. So in conclusion, targeted therapy has dramatically improved the outcome for patients with metastatic kidney cancer. Efficacy in the adjuvant and neoadjuvant setting is still undergoing investigation, but without complete responses from these targeted therapies, I would argue that surgery will remain an integral part of the multidisciplinary approach, both for control of the primary tumor and as well as metastasectomy, something we didn't have time to touch on today. Show me an agent that demonstrates reliable, complete responses, and I'd be the first to argue we'll re-examine the paradigm. And those of you in this room should not walk out of here thinking that presurgical therapy is the standard of care. It's not. It has merit, but it needs further study and validation. It's not clear to me when it would be most appropriate to integrate surgery into the context of receiving systemic therapy. And with that, I will say thank you very much for your attention. Jose.